Okay, so for those of you who I didn't say, my name is Keely, and Keely Baining, and I am the new owner of Superior Physical Therapy. I opened this business up about 5 weeks ago. I've been a physical therapist for over 20 years. I just decided recently to start my own practice. My specialty is in pickleball injuries and other racket sport injuries. One of the things I wanted to do when I started my business was to try to help people out there with kind of some of the misinformation that's out there about what should I do about my plantar fasciitis and whatnot. You know, I'm on all the pickleball forums and see the crazy stuff people type in to do for that stuff. And so hopefully this stuff will be helpful. It's based on some research and kind of what's out there in the literature. So I've tried to sift through that so you guys kind of know what's worth your time and learn a little bit about injuries. Okay, so this is the injury prevention workshop, and I did one about 3 weeks ago specifically on tennis elbow. I have part of that in here. I have more information on that if you're suffering from tennis elbow, but plan to do some more in the future. I don't have any planned right now, though. Can everyone hear me? Okay. Okay, so this workshop is for people who currently have issues. You'll get plenty of information on what you can do to try to prevent issues as well, but trying to manage some of those issues, learning about what are some of the risk factors, and if you can eliminate some of those risk factors, those can help you with your pain as well. So people who already have an injury and want to get back to pain-free sports, people who don't have an injury, this is actually, I'm hoping most of you don't have injuries because it's a lot easier to prevent an injury than it is to recover from one. And for those who are kind of confused a bit by the conflicting information out there, come on in. Okay. Welcome in. Come on in. You're good. We haven't done anything important yet, so. Okay, so we'll go over a couple things. 3 key ways to keep yourself injury-free, and that is learning what risk factors are for various injuries and pain, what kind of equipment choices can be helpful or harmful for your body, and then some exercises for either prevention or treatment if you already have a problem. So what's in it for you guys? Again, trying to prevent something, learn how to manage it if you already have it, but also understanding when should I actually seek someone's help for this problem. And so for those of you who are already dealing with pain or injury, I wanted to let you know that today, this is not physical therapy. This is not medical advice. This is general information. I think it'll be helpful and I think it's valuable. But true physical therapy and medical advice is after we do a complete examination on you and find out all of your risk factors and look at which muscles are weak and where you're tight and how your body moves and whatnot. But again, I think this is still very valuable, so you'll get plenty out of it. Okay, so why am I qualified to teach these things? I am a certified athletic trainer, which is what I went to school for first. And I am a physical therapist. Being a physical therapist, we are not required to do residencies, but I've completed one in sports medicine in 2006, 2007. So during that time, I basically spent a year away from regular patient care, studying with all the sports medicine specialists in the Twin Cities areas here. I'm also board certified as a sports clinical specialist, and I am a pickleball player. So I'm addicted just like the rest of you guys. Okay, so a little bit of housekeeping. I am actually recording today's video, which is coming in handy because some people were unable to make it because of the weather. So I ask that you don't specifically mention your personal health information. For both HIPAA reasons, we're not supposed to be talking in front of people about issues, and also because it's being recorded and it will be available online. But if you have specific questions for me, I want you to know that I am open to talking to you about that. So you can, I left you my phone number here. I'll send that out to you as well. Feel free to give me. Okay, so today we're going to go over plantar fasciitis, tennis leg, and this is like a specific calf injury that happens commonly in tennis, obviously with a name. Achilles tendonitis, or Achilles tendinopathy it's called. Achilles tendon rupture, tennis elbow, and then rotator cuff tendonitis and tears as well. Okay, so first we're going to go over plantar fasciitis. So the name plantar fasciitis actually means inflammation of the plantar fascia. It's the most common cause of heel pain, but unlike the name, it's not actually an inflammatory problem. It's actually called a degenerative problem. So degenerative means slow kind of working down of the tissue, micro tears, micro trauma to the tissue. An inflammatory condition would be, I decided this weekend I'm going to paint my entire house by hand, and I gave myself some inflammation. So inflammation, kind of a short-lived thing, where plantar fasciitis is, as if you've ever had it, no, it's a very long thing. So it's actually a degenerative condition. So the plantar fasciitis, or plantar fascia, is actually kind of part of our structure of our foot and our arch. So it gives us support, it helps us shock absorb, and so it's a really important structure for our arch. There's a higher prevalence in women than men with plantar fasciitis, and your peak age to get plantar fasciitis is between 40 to 60 years old. Who's 40 to 60? That's where I am, right in the middle of this. So, okay, so what are some of the risk factors? One of the risk factors is obesity. So just being heavier, putting more weight through your feet over time will put you at higher risk of developing plantar fasciitis. Also, people who have flat feet. So if your footprint looks like the middle one here, where most of your foot is touching the ground, that would be considered a flat foot. And so with them, they're going to have more strain on their plantar fascia because the arch isn't being held up very well by the muscles and the other ligaments and bones. On the other hand, people with really high arches are at higher risk of developing plantar fasciitis as well. People with high arches tend to have a really stiff foot that doesn't have much shock absorption in it. And the plantar fascia is put in kind of a little shortened position all day, every day. And so it doesn't take much to kind of start stretching that and causing some pain. Tight Achilles and calf. So our calf muscle connects on down to the heel, similar location to where the plantar fascia starts. If we have tight calves, we tend to try to make up for it somewhere else, and the foot is one place where we try to make up for that. Inadequate arch support. This has more to do with maybe if you stand a lot for your work and you're wearing flats or you're wearing flip-flops everywhere. So you're not having a lot of support for your feet and you're on your feet for long periods of time. Changes in activity level. So if all of a sudden you find this new sport of pickleball and you can't play an hour, you got to play 3 hours, right? So that just sudden increase in activity, everyone's giggling. So that sudden increase in activity, it can be too much for the arch and the arch muscles and the plantar fascia to get used to. And so you can injure yourself with just all of a sudden ramping up your activity quickly. The occupational factors we talked about, people who are on their feet for prolonged periods of time. People who do athletic activities, particularly runners, are at high risk for developing plantar fasciitis. And if you have weakness in the muscle in the calves and in the arches. Okay, so prevention. How do we prevent plantar fasciitis? Keeping yourself at a healthy weight is helpful. Gradually increasing your activity. So, me personally, I've learned some of these things the hard way, and some of it's learned through my job. I purposely tell people how long I can play, right? I can only play until noon. Even if I have nothing going on the rest of the day, I tell people I can only play until noon because I'm like everyone else. When someone says, let's play one more game, which turns into 3 more games, I'm no different than anyone else. And I find that if I tell people ahead of time, or I tell myself ahead of time, you're going to leave at noon, I'm more likely to do it. So sometimes that's a good idea. But gradually increasing your activity and not going from an hour to 4 hours of playing. Proper warm-up, I'm actually going to go through a nice warm-up routine that you can do on the court. And you'll find some of these are themes throughout. A lot of the calf and foot problems, very similar problems, very similar risk factors, very similar prevention techniques. So a proper warm-up, which we'll go through, wearing shoes that have adequate support or cushion. The foot orthotics, there's actually some controversy with this. Some research studies show that they're helpful. Some research studies say that they're not helpful. I would say if you have plantar fasciitis, maybe starting with an over-the-counter that doesn't cost very much is reasonable. Or if you've tried everything else, why not try some orthotics, certainly. So I wouldn't count it out. I don't know that it would be the first thing I would go to. And keeping your calves flexible and strengthening up the arch muscles. And I'm going to teach you kind of a way to do both of those things later on. Okay, so now Achilles tendinosis or Achilles tendonitis, okay? So Achilles tendonitis is kind of the common name that you'll hear. Achilles tendinosis is the official name. So why do we have two names for it? Because like other things, we really thought it was an inflammatory problem. So we called it itis. And you'll see that theme throughout today. Once they actually got in there and they did studies and they actually looked at these tissues under the microscope, they figured out, oh, there's not a lot of inflammation going on in these chronic tendon issues. They're degenerative conditions. So the word out there for everyone else, they call it tendonitis. In my world, I call it a tendinosis. It just means a condition of that tendon. Okay, so the Achilles tendon is the largest and strongest tendon in the body. We talked about it's a degenerative condition. It's typically found in the, what I call the mid-substance of the Achilles. So here is where it's typically going to be found. There is some people, unlucky people, that end up getting it more towards where the tendon inserts into the bone. They are kind of a little bit of different animals, and that one is a little harder to recover from. But these are from repetitive use, overuse. And so repetitive overuse could be one of two things. Either, I decide I'm going to train for a marathon and I'm going to start out at 15 miles tomorrow and I haven't done any training, right? I can give myself Achilles tendonitis certainly by doing something like that. So if I'm undertrained and I do too much, the other way that you can get this, which is the more common way, is I have an excessive biomechanical load, okay? There's something about my anatomy and the way that my body moves or doesn't move that puts excessive strain on the Achilles tendon. And then I keep doing the activities and it'll increase the strain on the Achilles over time. I don't know where they're talking that I can hear them too. Can you guys hear that? Oh, is that from there? It's very loud. Carries very well. Thank you. Say that again. Yeah, the biomechanical load. Yes, for sure. Mm-hmm. Thank you. I was actually wondering where the talking was coming from. So did I. Appreciate that. Okay. So this is seen frequently in elite runners. So elite runners, their lifetime risk is 52%. So 1 in 2 chance of getting this. Very high. But on the flip side, a third of the people who get Achilles tendinosis have a sedentary lifestyle. So this goes to show you that there's not one cause for this. It's multifactorial. And so our treatment's also different depending on the population. So what are the risk factors? For this one, obesity was kind of sometimes found to be a problem, a risk factor, and some studies said it wasn't. So we're not sure on that. There are some metabolic things that we think are factors, such as alcohol use and chronic kidney disease. The thought is that the dehydration could possibly cause increased friction on the tendon. Disruption of your electrolytes, reduced blood flow. So they're not quite sure why those things put people at risk for developing Achilles tendon issues. If you have reduced calf strength, that puts you at higher risk. If you use a specific antibiotic, quinolones, it's very common to develop tendon issues, multiple different tendons in the body, but this one in particular because there's so much force that goes through it. Again, it's an unknown mechanism, but they think it's maybe interferes with your collagen, which is kind of like the building blocks of your tendon, causing weakness in the collagen. And then some of those biomechanical factors, some common ones, we talked about the tight calf muscles. If your ankle joint is stiff itself, not just the calf, but the joint, that'll increase the strain on your Achilles tendon. And if you have something called medial collapse, which is your foot and ankle and knee kind of collapse in, and as I'm demonstrating that to you, you're probably going, well, who does that? A lot of people do that, and they don't know they do that when they walk, they run, and they jump. Men are more prone to this than women, and people who are over 50 are at higher risk. So how do we prevent it? You know, maintaining the healthy weight is probably not a bad idea. Limiting your alcohol, doing that proper warm-up that we talked about, which we'll again go over in specifics later. Gradual increase in activity. Some of these should sound familiar. Stretching the calves, strengthening the calves, and then also you can incorporate some agility and plyometrics. So agility is when I'm kind of changing directions, right? I'm trying to, like we do on the court, I'm going to all of a sudden go this way, then I'm going to all of a sudden go that way. Actually training yourself with some of that. And also incorporating some plyometrics. Now, if you already have this problem, you don't start out with plyometrics. This is a preventative thing. And so plyometrics is basically quick contractions of the muscle, such as jumping. And you don't need to be doing big old box jumps to be doing plyometrics, right? You can do some mini jumps in place and everything. And that's been shown to strengthen the tendon so they can take a little bit more force. Okay, so Achilles tendon rupture. This is super like in the news with all the football players having problems with their Achilles tendon rupture, but it's most commonly done in sports. And in the US, basketball is actually the most likely sport you are to injure your Achilles tendon, followed by football and then tennis. And then they kind of lumped some of other sports like squash, volleyball, and soccer together. So any sport that you're kind of making quick changes in direction. I was going to have videos. I was going to have videos of Achilles tendon ruptures. It kind of grosses most people out, and I kind of thought better of it. So we'll skip that. But if you want to Google them, there's tons of them out there, and they're almost always the exact same mechanism. So I'll slightly demonstrate this for you. So you're at the baseline and someone decides they're going to, instead of hitting a big overhead, they're going to do a little drop shot, and you think, I'm going to get there, and you take off. So my heel is kind of down and back, my knee is straight, and I'm taking off going in this direction. And the people will commonly turn around and look at who kicked them. So the most common complaint is someone felt like they were shot, or they thought someone kicked them, and they will honestly turn around in the video and look to see who kicked them. And for those of you who didn't hear, my mom tore hers doing a cartwheel, so you can do it with all sorts of different sports or athletic endeavors. People who are under 55 to 60 are most common to tear, I think mostly because they're most commonly doing pretty aggressive athletic activities. You're going to get this more in the males, 77 to 83% male. But you obviously as a female can certainly rupture your tendon. But people who are over 55 and also have a BMI that's over 30, so BMI is, you know, your waist to height ratio. So they're more likely to rupture it with non-sporting activities, right? People who are under 55, 77% of them were sport related. People who are over 55, only 42% sport related. And I think it's just kind of a drop off of how much sports we play at that age, so. Okay, so risk factors for Achilles tendon rupture. A lot of this research comes from professional sports where they track this kind of stuff, but it goes to show you that in the preseason and then the beginning of the season, we're going to get a good chunk of our ruptures. Why? Because we're maybe not conditioned yet for the activity. And then at the end of the season when we're really fatigued, right? So other things that put you at risk would be diabetes, hyperparathyroid, kidney failure, and different genetic factors. Steroids put you at higher risk, particularly if you get the area injected. Plantar fasciitis, by the way, very common to rupture if you've had multiple steroid injections. Those quinolones that we talked about, those antibiotics, put you at higher risk of rupturing your tendon. Certain medications for osteoporosis put you at a higher risk. And if you have a history of Achilles tendonitis, you can go on to rupture if you don't properly rehab that. Okay, so how do we prevent it? We should all know these by now. Proper warm-up, right? Gradual increase in activity, strengthen those calves, staying hydrated, and avoiding that, flat foot takeoff. If someone's going to do a drop shot and you're way back at the baseline, you're not going to get it anyways. I actually played pickleball yesterday with Marcus Sherrills. Does anyone know him? He's a former Vikings player, and he could get it. He ran around the court yesterday like no one I've ever seen. But the rest of us, I think, just let that ball go, and good for them for hitting that ball. Working on that agility and plyometrics and building a little bit that into your practice. So it doesn't have to be a lot. Like you'll see in my warm-up videos, I actually do some of it in my warm-ups, and that can kind of count as your agility and plyometrics. If you do have Achilles tendonitis or tendinosis, rehab it to try to prevent this, right? And you also don't want to rupture because after surgery, the rehab takes about a year to get back to your sport. And is it ever the same? Not the same, okay? Prevention is a lot easier. Okay, so tennis leg. So this is people who say they pulled their calf playing tennis or pickleball. All this stuff says tennis because that's what the research is in, right? There's not a ton of pickleball research, although there's starting to be. So anyways, it's called tennis leg, and it's a tear of the calf on the inside of your leg. In 66% of the time, that's what it is. It can also be a fluid buildup kind of between, there's three calf muscles, but two big ones. And so there can be actually fluid between there where they think they're kind of the sheath that connects the bones is getting some injury. That's about 21% of the time. And I highlighted in red here, blood clots, 10% of the time is the actual cause of tennis calf. And the reason I bring that up is if you pull your calf, I personally would be going into the urgent care and getting an ultrasound of my calf because 10% of the time, 1 in 10 people will have a blood clot. And what happens to blood clots if they leave the calf? They go to your lungs. That can be deadly, okay? So I don't care how stupid you feel. You go into the ER or the urgent care and you get it ultrasounded. I'd rather 100 people go in and get 100 clear ultrasounds than the one person who goes, I know what I did. I pulled my calf, and they get the blood clot. So 10% of the time, that's the true cause. 5% of the time, you can get a blood clot secondary to one of the other injuries. So the other causes are much less frequent. Rupture of the plantaris, which is a small little calf muscle. In fact, some of you don't even have one. And then rupture of the soleus, which is the second calf muscle. So risk factors and causes, if anyone has ever felt a pickleball court, it's very coarse. And we've got these great shoes now, and we have this great traction where we're suddenly changing directions very quickly. It puts a big stress on our calf muscles. Inadequate warm up, right? I don't know about you, but I know plenty of people that show up at 5 to play at 5, right? So inadequate warm up, inadequate training. You're not doing things that kind of get your calves used to doing that activity. Having tight calf muscles will make them more susceptible to being strained. Having a previous calf injury makes it likely that you can have that again. So inadequate support and cushioning can be a risk factor. Now, for those of you like myself who are over 40, our muscles lose elasticity. So if you think about an 80-year-old or an 18-year-old who's more flexible, right? So we all lose elasticity in our muscles. And as we get older, unfortunately, a lot of us, not everyone, a lot of us do not warm up as formally. If you think your kid's going out there playing their high school sports and they're warming up for quite a bit beforehand. And like I said, I know plenty of people that show up at the time they're supposed to start playing. They dink 10 balls and then good to go, right? So I'm urging you to not be that person. Okay, so management of tennis leg, I get asked this a lot, like how long does it take to rehab this? Well, if it's a minor one, it could be anything from 4 to 6 weeks. If it's a more severe one, 3 months plus, right? Some of these can be really tough to come back from, and people try to come back too soon and re-injure it, and they start the whole process over. The complications we talked about with the blood clots, there's also a complication of something called compartment syndrome. And not to freak everyone out, but I think it's at least good to know about this. So if you have this, you would know exactly what to do. So compartment syndrome is our calf muscles are in a compartment, right? There's fascia that surrounds our muscles, and that fascia does not stretch, okay? So if all of a sudden I've torn my muscle, now I have bleeding and swelling in that compartment, and that is taking up my precious space. Some people have a little more space, some people have less space. So if it's taking up my space, at some point it can cut off the blood supply to the nerves and the muscles. And that is an emergency, and they will do an emergency surgery on you, and you'll have awful scars. But most of the times this is not happening. But if you are the unlucky one that has that, you want to know. If you start getting tingling and you losing sensation, your legs kind of changing color, we go into the emergency room with that. How else would you manage it? You know, icing and elevating. And then we try to get people to avoid limping, which might mean using crutches depending on how you're looking. A couple of days on crutches can do wonders for people. The ones who struggle and try to get without a crutch end up kind of taking a little bit longer to come back and hurting their back and other things in the process. So prevention, I don't have anything new with the calves here. So we're going to warm up properly, progress our activities gradually over time, stretch and strengthen the calves, and then we can work on the agility and plyometrics. So now I'm going to actually skip this part, the videos of the Achilles tendon ruptures. And I'm going to go into the dynamic warm-up, and then also what some of those exercises would be, okay? So dynamic warm-up, so a lot of people ask me, should I stretch before I play? No static stretching before you play. So static stretching is, you know, I'm going to grab my foot and I'm going to hold on and I'm going to stretch for 30 seconds. Why? Research has actually shown that you're more likely to injure that muscle if you stretch before you play. However, that doesn't mean we don't warm up. It means we do a different type of a warm-up. So a dynamic warm-up is, I'm going to stretch that muscle, but I'm going to do it with active movements. So the goal during my videos of the dynamic warm-up is you can see that I'm putting these muscles on a stretch and using these muscles, but I'm doing it in small little bursts, not holding the muscle and prolonged stretching. We can, however, do the static stretching after. So if you have an area where you know that area is tight, it's a great time to stretch is right when your body is really warm and you're done playing. That's your best time to stretch. Or if you just want to work on your mobility and stretching in general. Ideally, we break a sweat before we play. So if you're at a facility that has a bike and elliptical, hop on for it don't be there a half hour, just 5 minutes to get your body going enough that you get a little sweat. If they don't have one, kind of doing little jumping jacks or something in place. And then I'm going to walk you through all the different videos. For those of you that don't follow me on Facebook, I do have the entire video on Facebook of this stuff, and it is longer than what I'm going to show you today because I'm going to do higher impact activities and lower impact activities to give you options for some people who maybe their knees don't want to do some of the things I'm going to show you in this video. So if you care to look at that, you can watch it on my Facebook page, and it's 8.5 minutes, so it's boring, but at least you can watch it one time and get an idea. So here I'm going to show you some side shuffling. I'm only doing it at a short distance just because I'm making a quick little video for you guys. I certainly would go down and back a couple times. And all of these serve a purpose, bringing up your heart rate, bringing up your tissue temperature, and then warming up various muscles and stretching various muscles. Yeah.
So I do this at home.
Yeah.
But then if I wait like 10 or 15 minutes before I get my first game,
if you're still warm, if you're still warm, you're good. You might want to do a couple things, maybe 10 squats, before you get on the court or something like that. But if your body is still warm, then you're pretty good. Yeah, it's like if I live 30 minutes from the court and I do that, probably too long. Yeah, but if you're still pretty warm, then that's fine. Grapevine, I'm doing a high knee version. You certainly don't have to kick your knee up that high, but getting some crossovers in is a great warm up. I'm doing some high knees and pumping my arms. This will get your heart rate up real quick if you haven't ever done this. Okay. And you don't have to do all of these. These are just some ideas. Butt kicks. This is going to stretch out my quads as I warm up because I'm kind of kicking my butt. So I'm getting a nice little quad stretch with each one of those. Trying to pump my arms, getting a little blood flow in the arms as well. Walking lunges. I'm going to point out that my knee is not going in front of my toes on any of these, which is best for your knees. I also can vary the height of this. I don't have to go that far down. So walking lunges are a great warm up for your legs. Get a little hip flexor stretch in there.
What about people that have knee replacements?
Yeah, you can do them. I just wouldn't do them as deep. I wouldn't say you have to do them less deep. I would say you probably can't do them as deep, but if you can, some people can.
They just like told us like backward lunges or side lunges.
Yeah. So yeah, if you're not, as long as your knee isn't going in front of there, it's not a ton of strain on your knee. But like there's a mini lunge, and I'm not going that deep. So doing a little mini lunge like that instead of a really deep one, you can go backwards.
Yeah.
If you don't mind doing that. And then I'm going to show you side lunges as well in the video. Frankenstein walk. So this one I'm pulling my toes up and kicking my legs. So I'm getting a hamstring stretch and a calf stretch at the same time. And it looks really cool. I do a lot of this stuff before I play. So I don't mind people looking at me like, what is she doing? So getting the body warm. This is a walking piriformis stretch. It's a great stretch for your hip and butt. It also works on your balance, as you'll see with me struggling to maintain my balance throughout. Me personally, when I do this, I notice that my left side is really easy to sit into, and my right side, I just can't quite do it. So that would be something where after I play, I can target that with a more prolonged stretch, right? So sometimes these things you kind of figure out your own little deficits, and then you can use that to decide what to do after. So this is a great exercise for pickleball players. It's a side lunge. It stretches out your adductors. So if you ever get groin pulls, it's great for that. It kind of works on your dinking technique at the same time. You also don't have to go as deep. So I'm showing a moderately deep position, but you can do it less deep as well. I'm just pointing out that my knee is back. I'm not letting it go in front of my toe. I'm pulling my hip and butt back to keep my knee behind my toes when I do this. So I'm going to do a little forehand dink, and then I'm going to go to the other side, a little backhand dink. And you're kind of going back and forth. You'll feel a nice stretch with that, and it strengthens at the same time. It's a really good exercise. Ankle swipes. This is another one for hamstring and calves. I'm just have my knee straight. I pull my toes up, and I'm just reaching for the floor. If you've never done that, this is a great stretch for your hamstring and calf at the same time. I'm going to fast forward this one because it's pretty slow. And then I'm showing on this one a drop step for hitting overheads. I have this in here because, yes, you can use it for a warm-up because it warms up both your arms and your legs, but actually also injury prevention. I wanted to talk about this today. If any of you have heard not to backpedal to hit your overheads, we get a lot of injuries with backpedaling, so wrist fractures, head injuries, and such. So I would urge you to practice this if you've never done this. I was a college softball player, and so as an outfielder, this is all I did. So it's very natural for me. But if you didn't do that kind of thing, maybe you've never done a drop step, practice this at home. And this is the way you should go back for lobs. So there's me backpedaling. Don't do that. I'm yelling at you in the video. You're going to break something. You're going to hurt something. Okay. So now you're going to see that I can drop step. So I'm going to get into an athletic position. I can drop over either shoulder by turning my hips and shoulders and my feet. And then I'm going to get to wherever the ball is ahead of time and then hit the ball. And then I can run up. And you can do this forehand or backhand. Get to where you're going to be, run yourself up to the net, right? So that's a great injury prevention, but also it's a good warm-up at the same time. Okay, so now we're going to talk about a couple simple exercises to cover the plantar fascia, the Achilles, the calf. I kind of picked in a couple exercises that kind of do a little bit for all of them. And so here you see me standing on a weight. So this weight is just a couple inches high. At home, I would just stand on your bottom stair to do this. And so what you're going to do, so let's say I have an Achilles tendon problem on my right side, or a plantar fascia problem on the right side. I'm going to go up on both feet, and I'm going to take a couple seconds to get up. Don't go real quick. Get up there. My calf's about to cramp. Well, too much pickleball yesterday, maybe. So you're going to go up on your feet. You're going to take that uninjured side away. I'm going to stay up on my foot, and then I'm going to slowly lower myself down. Now remember, I'm on a little bit of an edge, and so my heel is going to drop down. If I'm on this little thing, which is not very high, my heel will hit the ground like it is in the picture. If I'm on the stair, I just go down as far as I can go. Just going to mention that if your Achilles tendon problem is lower, we do this different. So that the people who have this where the problem is on the heel bone itself, we just do it different. Everyone else, this is the way we would do this exercise. In the instructions, I also say there you can put a rolled up towel under your toe. This is specifically for plantar fascia. So if I put a little towel under my toe is now going to be, I can't even do it, pulled up, right? And then I'm going to go up onto my toe. It's really going to stretch the bottom of my foot and the bottom of my toe where the plantar fascia goes. So you can do that as well. I'm not doing it in the video, but that would be another version of this. So for stretching the calves and the plantar fascia, the easiest way to do this is to go up to a wall. The picture on the right, I'm doing this with my knee straight, my toes up on the wall, and then I'm just gently leaning in. I'm getting my stretch on my plantar fascia because my toes are on the wall, and I'm getting it on one of my two calf muscles. And I say that because you have to do the second one, which is what most people don't do. You have to do the second one with your knee bent to get the other calf muscle. And so, so you see the picture on the left, my knee is bent, and so you do want to do that one as well. You'll feel that a little bit lower down. And you hold your stretches after you're done playing for about 30 to 60 seconds or so. Okay. If you happen to have one of these slant boards in your club, you can use them as well. So again, we just do two different versions. My toes are straight, my knees are straight, I lean forward. Or my toes are straight, my knees are bent, and then I lean forward. Okay, so same idea. And I'm going to give you, again, pictures and videos of all these exercises with instruction and all of that. Okay, so now we're going to move on to the upper body. So tennis elbow and rotator cuff issues. So starting with tennis elbow, let me get a drink of water. I feel myself getting dry here. It's the most common cause of elbow pain. And tennis players will get this 35 to 51% of time across their lifespan. So if it hasn't found you yet, it may be coming. It's most commonly seen in the 35 to 55-year-old. It's common also in manual laborers who do repetitive manual labor, heavy use of their arms, repetitive things. And as we all know, it's common in racket sports. So what is tennis elbow? It is a degenerative condition similar to the other tendon issues. So the name of it is actually lateral epicondylitis, which you might have heard. But as we know, it's not actually an itis, so we call it lateral epicondylosis. But anyways, you don't need to know that, but the tennis elbow is a degenerative condition. There is a specific muscle called the extensor carpi radialis brevis, or ECRB for short. That is the most commonly affected tendon. And tennis elbow affects the tendon kind of where it inserts into the bone, okay? And the bone is called the lateral epicondyle, so that's where the name comes from. It is caused by repetitive microtrauma to the tendon. So some people say, well, won't this go away on its own? 6 months to 2 years probably will go away. But if you continue to play your sport or do your manual activity, it is more likely to linger, right? And for 10 to 20% of people, those symptoms will persist more than a year, and it can reoccur in people who have previously recovered. So if you're someone who had tennis elbow years ago, you may not 100% be in the clear, so keep that in mind. Okay, so what are the risk factors for tennis elbow? Well, some of them we can do something about, some of them we're stuck with, like age and gender. So I'm going to go through a little bit of statistics with the elbow, so bear with me. You'll get all of this, but age is a big factor. So if you're over 40, you have a 4-time increased prevalence if you're a male. And if you're over 40 and female, you have a 2-time increased prevalence. So age is a big factor, as is gender. One of our biggest risk factors, which is something we can modify, is how much time we're on the court. And everyone hates this slide, but I'm going to read it anyway. So players who are under 40 years old, who play for 2 hours or more, are at twice the risk of developing tennis elbow than those who played less than 2 hours. But if you're over 40, and you play 2 hours or more per day, you're at 3.5 times the risk of developing tennis elbow than those that only play 2 hours a day. Another study looked at people who already had tennis elbow, and they looked at how many hours a week they were playing. And those that have tennis elbow typically play 8 hours a week, and those that don't have tennis elbow typically play 5.5 hours a week. So your amount of time per session and your amount of time per week do matter. So that's why I tell people I'm playing for 2 hours and I can only play on these days, right? I'm doing it partially to prevent issues and prevent things from developing worse than they are as well. Your technique matters, your experience matters. So research shows that the further off center you hit the ball, the more vibration goes through the tendon in the bone. And so like 3 times greater magnitude of the vibration if you hit it off center. So then they looked at kind of more novice players versus expert players and showed that the vibration loads are much higher in the beginners than it is in the expert. As you can imagine, they're probably hitting it more consistently in the center of their paddle or racket. There's a technique difference oftentimes in expert or advanced players versus novice. And this is with one-handed backhand. So if you don't do a one-handed backhand, you can snooze for a minute. But so the expert players will hit the one-handed backhand. At ball contact, they are extended in their wrists. So I'm going to hit that ball and I'm already extended. The novice players are going to hit that ball with their elbow flexed. Now, those of you who sit up at the kitchen line and hit backhand rolls and flicks, that just the nature of that hit is going to be harder on your tendon, and that's unique to pickleball. They don't find that maybe in ping pong or something, but so just the nature of pickleball, we do have more stress on our elbow. Some other risk factors that we can modify are your strength. So there's different studies. One study looked at the strength of my dominant arm versus my non-dominant arm to see if there's differences in the strength. And then they're comparing those to other people to make sure it's not just dominant versus non-dominant. And then there's also ones where we took people who already have tennis elbow, looking at their dominant arm, and then looking at another group who has never had tennis elbow, and what is their strength, right? So what they found was that there's weakness in the rotator cuff and shoulder blade muscles, as well as the wrist and forearm in people who have tennis elbow. Now, what I wanted to say about that is I'll go into this in a little more detail. Rotator cuff, there's 4 of those, and they all have a different role. So this is just generalizing rotator cuff weakness, but you need to know which one of your rotator cuff muscles is weak to figure out which ones to strengthen. There's 17 shoulder blade muscles. Okay, so me saying shoulder blade weakness, there's a lot of different exercises, and some of them could be valuable to you, some of them couldn't. It's nice to know which muscles are weak so that you can determine what your best exercise is. Okay, so grip size, does it matter? So there is a common myth, I say myth because I think I'm disproving it a bit in my research here, that the size of your grip, if you have tennis elbow, you should go to a bigger grip, okay? So this is said in the medical community as well as people on different forums are saying this as well. So let's look at the research. What does it say? So there's several studies that looked at small grip, medium grip, and large grip. And they said, some of the studies said, well, there's no difference in how much force goes through your elbow if you're using small, medium, or large. So those studies said, doesn't matter what size you use, you shouldn't change it because you have tennis elbow. It's not going to make a difference. Other studies looked at the same thing, and they found that the smaller grip and the larger grip both increased the force on the elbow and tendon. So the medium size was the least amount of pressure on the elbow and tendon. So the higher the grip force on the handle increases the higher the vibration, which is why you probably hear people say don't grip so hard. It does correlate with a vibration on the elbow. And then several studies found that the large grip size increased the force even more than the small and certainly more than the medium. So I think that's actually wrong for people to say grab a bigger grip size unless the size you're using is not the right size. Players over 40 that had larger grip had a significantly higher incidence of tennis elbow. Okay, so my recommendation is to use the recommended grip size, which you're going, well, what is that, right? So there's 2 methods for measuring this. One of them, you're going to measure the tip of your middle finger, or your ring finger, down to the second crease in your palm. So if that was 4.25 inches, then the grip you want is 4.25 inches. Now, this is kind of getting nerdy, but Chris Olsen of the Pickleball Studio, if anyone knows who he is, he's a Minnesota guy, and he's well known across the country for pickleball, and he looks at all the paddles, and he writes down all this junk. So if you really want to know, you can go on his website and search it out. An easier method is to take a paddle. So you take a paddle and just loosely grip it. Don't give it a death grip. Do a little loose grip. And then you want to be able to just barely fit your finger between your palm and your other finger. So if I got to wedge it in there, it's probably too small. If I got a big gap there, it's probably too big. So that's a quick and easy method for that. I also brought this paddle today because this has been engineered specifically for tennis elbow. And I have played with it. Let me tell you, it's a little hard to control. It's a little wild because there's so much power in it because the force goes back on the ball, not on your elbow. So if you're really looking for all the options, it's a ProKenix Ovation. They have different ones that are made specifically for tennis elbow. Okay, so new fad is adding lead tape to your paddle. Has anyone added lead tape here? Yeah, okay. So I did, I took it off. So adding lead tape, so the idea is if you add it at the end of your paddle, you're getting more power. If you add it in the middle of your paddle, it's going to increase your sweet spot a little bit. And at the bottom, it's going to give you a little more control. So everyone's, putting lead tape all over their paddle. Well, Chris Olsen that I mentioned looks at the swing weight of paddles. And the swing weight is a good determination of how hard is it going to be to bring that paddle through the zone. So the heavier the swing weight, the more work it is for me to swing that paddle, which means a lot more work on my elbow. So you want low swing weight. And we know that every single paddle he's looked at where he added weight, it increases the swing weight, right? So no matter where you put the lead tape, it will make it harder to bring that through the zone, which means more stress on your tendon. If you put it at the end, it's considerably more. So if you're going to use lead tape, put it near the neck. I would urge you not to use it. I have some anecdotal things. I have a friend who had never had tennis elbow before in his life, put lead tape on, started developing tennis elbow, smart enough to know what he did, took the lead tape off, let it calm down a very short period, back playing, no problem. Another guy had tennis elbow bad enough that he had surgery, and he was probably pain-free for about 6 months and playing a lot. And he added lead tape and started developing his tennis elbow again. Because he had had surgery, he's like, no way. Took the lead tape off, and pretty shortly he was able to recover. So my experience is it's not a good idea. I understand why people do it, but if you're really trying to prevent this, I wouldn't use that. Yeah. So it's I don't have any on here, but it's either lead or tungsten, tungsten I believe, and they come in either little strips or you can cut them a certain length, and you put them on your paddle. So you'll see people have them on the sides of their paddles. I don't know. Like I said, it does change how it feels and how it plays, but at the detriment to your elbow. Okay, so then you see everyone wearing their little tennis elbow braces, right? Do those actually work? Well, okay, so research shows that they do reduce the stress on the elbow muscles. They improve your pain, and they improve functional outcomes. Functional outcomes are when you go to the doctor and you have to fill out the paperwork that says how hard is it for you to do, A, B, and C. So all of those things improve, mostly in the short term, but they do improve. So if you don't have tennis elbow, I don't recommend just wearing one for the fun of it or try to prevent it. But if you do have tennis elbow, I definitely recommend trying a tennis elbow brace. The kind that work best are the kind that you can really cinch up pretty tight. You don't want to cinch it up so tight your hand turns color, but you do want it pretty snug. The idea behind it is, when I'm hitting, that vibration goes into the muscle in the tendon right where it inserts into the bone. If I wear this brace, some of the force is going into the brace instead. So it's just taking away some of the constant irritation on the tendon. Okay, so exercises for tennis elbow. So I brought 2 little equipment things to show you. One of them you can probably do at home without much equipment at all. One of them you have to buy something. So I'll give you both options. The one you have to buy something, you only have to do once a day. When you don't have to buy something, you have to do it 3 times a day. So there's value in both of these. All right, so the first one is called eccentric strengthening. So the word eccentric, all that means is my muscle is lengthening as it's contracting. So if I'm going to do a bicep curl, this is concentric. My muscle shortened as I contracted it. Eccentric is it's lengthening as I bring the weight down. So I'm still contracting the muscle, but it's lengthening. It's been found in research to be very helpful for chronic tendon issues. So they did a study where they're comparing doing concentric exercise versus eccentric on tennis elbow, on chronic tennis elbow. And the eccentric was better at reducing pain and improving muscle strength in people who had chronic tennis elbow. So that's why we recommend it. So what you do is you take your unaffected hand and you lift the weight up with that hand. Then you're going to let go. And then you're going to slowly, over the course of 4 seconds, bring the weight back down. Put your other hand there, lift it up, hold it there, slowly lower it back down. Okay? Boring as can be. It seems stupid that you're helping it up, but it helps. So that would be how to do that one. Now, this is a 2-pounder, and I think one is pretty light unless you're like really flared up or pretty wimpy. 2 pound is where most people kind of can start, but 1 or 2 pounds is certainly fine. And then you can go up in the weight a little bit over time, but we're not getting up to 10 pounds or anything. So if you are pretty flared up, elbow bent is going to be how you're going to want to start that exercise. And then over time, you can do that with your arm straight. I would do this, by the way, leaning my arm on something so I'm not holding it up. That's quite a bit for the shoulder to do for 3 sets of 15. So I would have my arm supported on something like the picture they have it on a table. So the research shows that 3 sets of 15, 2 to 3 times a day, does really well with tennis elbow over the course of months. So this isn't I start it Monday and by Friday I'm feeling good. Okay, so you do have to do this for quite a bit of time. It's very like monotonous, and you don't have to think about it once you're doing it. So you put it on the coffee table, and while you're watching your show, do it. It's pretty easy, but okay, so that's not preventative, but if you have it, which I did write, and thank you for reminding me, if you do not have tennis elbow and you want to prevent it, you can go ahead and just do concentric and then slow eccentric. Okay, concentric up, slow eccentric down. So you don't have to do the whole help it out thing if you don't already have tennis elbow. Okay, next one. So this was the one that you only have to do once a day. It is called the Tyler Twist, named by the physical therapist who came up with it. You do have to buy one of these. I am not promoting this, but it's called Flex Bar, and you can sell them on, or you can buy them on Amazon for about, I think it's $20. They come in different colors. For most people, I recommend starting with the red. You do not have to memorize this. You won't remember by the time you get your Flex Bar, but I'm giving you the video, so I'm just going to show it to you. So, because there's a lot of steps and you're never going to remember it. So you're going to extend your wrist. You're going to grab this with your opposite hand. You twist it, extend it, and then I'm going to slowly, over the course of 4 seconds, lower that down. I bend it back, I twist it, I extend it, and I slowly lower that down over 4 seconds. So this is also 3 sets of 15. You only have to do it once a day over the course of months. So no quick fix for any of this stuff.
Could you say again what biomechanically you recommended for hitting the ball to avoid it in the first place?
Yeah, so if you're doing first of all, if you can do a two-handed backhand, do a two-handed backhand. I'm trying to teach myself a two-handed backhand for that purpose. But people who are more advanced, when they hit their two-hand or their one-handed backhand, their wrist is extended, which means this direction. So as I make contact with the ball, I'm already slightly extended at the wrist, versus beginners are going to hit that more like this, right? More wristy, and they're going to hit that like that, which is a lot more strain. However, at the net, if I'm doing a flick and a roll, I mean, that's just the mechanics of that, right? So two-handed. So I think if you are new and you want to learn a two-handed backhand, I'd for sure recommend that. If you watch any of the female pro players, it is fun to watch them kill the ball two-handed backhand anyways. But if you're developing tennis elbow, why not learn a two-handed backhand as well? Okay, so now we're going to move on to the rotator cuff injuries. So the shoulder is kind of my passion, so I'll get a little excited here about this. But so the shoulder joint itself is a ball and socket joint, but it's not a ball that sits inside of the socket like our hip joint is. This is a golf ball, and it's sitting sideways on a little golf tee. So if you have a golf ball and a golf tee, the wind blows right, the ball falls off, right? So the shoulder joint is a very unstable joint, and it's unstable because we need to do all this stuff, right? I can't do all that with my other joints. They just do kind of one thing. So it's a very unstable joint in how we're built. Therefore, we get a lot more problems with it. So you hear a lot about shoulder dislocations. You don't hear a lot about elbow dislocations or hip dislocations because they're just naturally more stable of joints. So the rotator cuff, the 4 muscles of the rotator cuff, is your primary stabilizer of the ball and socket joint, which is why we have a lot of problems with the rotator cuff muscles, because they're not just like the bicep moves, my arm bends and straightens it. It's not really stabilizing the joint. The rotator cuff is stabilizing and moving the joint, and they're tiny little tendons. Also, it's a little bit hard to see here, but you have a bone here, which is also the same bone here, that creates a roof over the rotator cuff, okay? And that little space under the roof is pretty small, so there's not a lot of space for the rotator cuff naturally, and naturally the rotator cuff doesn't have a great blood supply. So I've just named off a whole bunch of reasons why rotator cuff issues are pretty common. All right, so next up, so of all tennis injuries, 4 to 17% tend to be overuse problems of the shoulder. And I found some really interesting studies. So there's 2 studies, both looking at asymptomatic people who played tennis, or groups of people, and they found that in the dominant shoulder, so these people do not have pain, 40% of them have partial or full thickness tears of their rotator cuff and have no pain. And then they did another study where they did elite adolescent tennis players, and they found a significantly higher frequency of tendonitis already in their shoulders without having any pain. So this tells us that the nature of and their non-dominant side, by the way, did not have anything on all these people. So it is their sport. So just the nature of overhead, repetitive racket sports, we know it puts more strain on the rotator cuff, okay? Degenerative tears are common, and they have increased prevalence as we get older as well. Okay, so what are the causes and risk factors? So a loss of shoulder internal rotation. So what this means, or a way to measure this, is if I stick my non-dominant arm, go up my back, I can go to a certain height, and then I do that on the dominant side, dang, it doesn't go up as high, right? So everyone try this out. Put your non-dominant arm, sit up tall, put your non-dominant arm behind your back and just kind of make a mental note, how high did my thumb go? And now take your dominant arm and give her a whirl. Uh-oh, I saw a couple cringes. So not only is this a risk for shoulder issues, this is actually a risk for elbow issues as well. Okay? So this is important. Now, my kind of general thing is if you're within about an inch, okay, right? But if we're 2, 3, 4, 5 inches off, I see people who have frozen shoulder all the time. I see people who've had surgery. So I've seen people who, here's their internal rotation, right? They can't even get to their butt cheek. So there's a whole host of them. But if you're more than an inch off, that is significant. Another cause of this is something we call scapular dyskinesis, and this is just a fancy way of saying your shoulder blades aren't doing the right thing. They're moving kind of funky. And the reason why it matters is because your socket is your shoulder blade. And so if your shoulder blade is not doing what it's supposed to be doing, that's going to change what happens at the shoulder. Your rotator cuff lives on your shoulder blade. So if it's not being stabilized properly, it's not going to be able to do its job. So this is something that I look at in my assessment and seeing what your mechanics of your shoulder blades are doing. But it also makes less space for the rotator cuff. So it is a significant issue. And then we talked about repetitive, rapid deceleration of your arm. So when I do an overhead and I make ball contact, the whole follow through, significant force is on the rotator cuff. Same thing with forehands and backhands. So it's harder. The follow through is harder because the muscle is contracting as it's lengthening. So it's doing that eccentric contraction. So microtrauma and eventual tendon failure you can have. So how do we prevent this? I'm going to teach you an exercise, especially for some of you who have tight shoulders, to maintain or improve your internal rotation. And then you can do shoulder blade strengthening and rotator cuff strengthening. Remember, there's a whole bunch of muscles there and there's a whole bunch of mechanics. It's very complex. I'll give you kind of the best of the best from research standpoint, meaning it covers some of the more commonly weak ones. I'll give you an exercise for that. And then just improving the mechanics. And that's something that requires someone to help you with that. Okay, so why do we want to do this? After surgery, boy, I tell you what, if there's a surgery you don't want, it's the rotator cuff repair. This and Achilles tendon repair are some of the longest recoveries we have, where 8 to 12 months out, you are not good at 8 to 12 months out. You might be playing when you get closer to this point, but it's not the same. It's a very long recovery. So research shows that the overall return to sport after a rotator cuff surgery, depending on the surgery, is 65 to 85%. And returning to the same level of play, you're more likely to return to the same level of play if your level of play is not real high, right? So recreational players tend to get back to their same level in theory, and competitive athletes usually do not. And that goes to show you that people don't fully recover after this surgery. Okay, so now I'm going to show you a couple exercises here. So this is the sleeper stretch. So this is a stretch for those of you who have the tightness already. If you don't have the tightness, you can just do it a little bit to maintain. And so you're laying on your dominant side, your elbow's even with your shoulder, you're rolled up kind of on your side, and then you're just going to gently press your hand down. You are never going to touch your hand to the bed or the floor, so don't try. If you do, you're cheating with something. So just when it feels like it doesn't go any further, that's where you hold it, okay? And you hold that for 30 to 60 seconds. Best time is to do that, I'm supposed to say perform, not preform, but perform that after you play. And then for strengthening of the shoulder blade and rotator cuff, I picked an exercise that does both. So there's weakness in the shoulder blade and rotator cuff. This does both. You're basically going thumbs up, elbows straight, and going out to the side and coming back down. Going out to the side. I wouldn't necessarily recommend doing it this way. It's not the end of the world, but it is harder on your back. So you can do this on a ball. If you don't have a ball, you can lay on your bed and have your arms off the edge of your bed or something like that. Okay. So summary of what you learned. Injuries are common in sports, right? Tendons tend to degenerate with age and repetitive use. Degenerative tendons can go on to tear and rupture. Prevention is the best cure. There are many causes and risk factors for injuries. Once you have an injury, kind of the best comprehensive care is getting individualized treatment where we assess you for your issues. It's much easier to treat earlier on than later. So if you think like, oh, this will probably go away, I'd rather you come in for 1 or 2 visits and learn what you should do about it than need, so many visits in so many months and you're miserable and missing your sport. Proper warm-up includes a dynamic warm-up, not static. If you do static, we do it afterwards. So today I'm offering for people who came to the event, you can get a free kind of injury assessment by me. It's not a full evaluation, but it's kind of me finding out what your issue is, kind of doing a little bit of exam just to kind of see what would be your cause of this. Is it something that we feel like we could treat? Would we be a good fit? Do we need to refer you somewhere? Something like that. And then if you feel like this is where we need to be, then we can decide if we wanted to move forward with formal therapy. Because it's not paid, I only do a couple a week. So I'm offering 3 of those. But for those who want more the full evaluation and the full treatment, which is a 60-minute treatment, I am offering that at 50%, but you have to sign up today for that if you'd like that. And I'm offering 4 of those. There was supposed to be more people here, so that's actually a good ratio. Okay, so next steps. You're going to put this in practice. You're going to show up 10 to 15 minutes early to play to warm up. Okay, it doesn't have to be a half an hour. Just show up a little bit early. I'm going to be sending out an email with the slides and then with the exercises for you to do. And then if you're having pain, let me know and we can kind of figure some things out. Any questions?